Hello, I'm Dr. Maury Markman from City of Hope. And in this week's segment of Minutes with Markman, I would like to continue the discussion that began last week on the impact of HPV vaccination, the development of cervix cancer, and other HPV-related malignancies. There have, of course, been many papers over the last decade or so that have revealed the substantial benefits of HPV vaccination as a cancer prevention strategy. The early studies looked at dysplasia, known precursors of cancer, but increasingly we're getting data that demonstrate the impact on incidence of invasive cancers. Obviously, this takes a long time to be able to show from the time you vaccinate, the prevention of the persistent infection, et cetera, to get to the cancer association. So we're getting more and more long-term studies that show the impact, including population-based studies looking at a variety of countries' experiences. Critically, these studies, the trials that have been conducted, were certainly in the past looking at placebo controls in this setting. In addition, the issue of toxicity, which continues to come up, has been addressed. And the answer there is there simply is no evidence for serious toxicities of any kind that relate to HPV vaccination compared to a background control population in the real world. So I want to mention just a couple of studies that have recently been reported that expand upon the data that we've had in the past, longer follow-up, larger patient populations, overwhelming data. Two studies I want to mention. First, from the Cochrane Library, a network analysis recently published of randomized trials, 60 studies involving 154,000 research subjects with a follow-up from a minimum of 7 months to out to 11 years. Bottom line, if you look at CIN2 plus matched to the HPV type, in other words, 16, 18, et cetera, whatever was in the vaccine, population-based data. Here, we're looking at, again, population in these patients who are on the trials and what happened to them over time. There was a 60% reduction, 60% in the incidence of CIN2, recognizing that, of course, much happens to these patients over time, recognizing that some of these patients actually had persistent infections even before they were vaccinated. There was a 60% reduction based on these studies. And critically, no difference in the incidence of serious side effects. The next paper, I believe, is even more relevant because what we're looking at in this analysis was a review of population-based, not randomized controlled trial data, looking at HPV programs on the incidence of HPV-related disease and toxicity. There were a total of 225 studies included in this analysis that included a population of 132 million people. It included randomized extension trials, and what I mean by that is randomized trials were conducted, but this was after the trials were completed, and may have been more people that were entered in the population base rather than as part of the original cohort in the randomization. Cohort studies, case control studies, cross-sectional pre-vaccine introduction studies. Again, large number of different trials that were looked at. It should be noted that 177 of these studies included in this large analysis included only females looking at cervix cancer, and there were only 11 studies that only included males. Again, understanding that the focus in the vast majority of these studies was cervix cancer, not oropharyngeal cancer. And I think this is an important point we'll come back to actually in the next segment of Minutes with Markman as regards what we need to do in the future. So in the analysis that I described, if one looked at the studies that were specifically looking at cancer incidence, there was a hazard ratio of 0.37, meaning a 63% reduction overall in the incidence of cervix cancer in the population that received the HPV vaccine. And if one looked at specifically individuals who younger than age 16 when they were vaccinated And we were looking at a population that had received, had been followed with a reasonable period of time. There was an 80% reduction in the risk of cervix cancer. Another study that is to be noted was a trial that was recently reported from the Swedish National Cervical Screening Registry. In Sweden, as in many other countries, Scandinavian countries, there are registries that capture these particular diseases that are considered to be very appropriately public health concerns. And one look at data here from 1985 to 2000. Now, clearly, the earlier days were long before there was an HPV vaccine, but in fact, the incidence of cervical cancer was captured. And what one saw here, that in women who were not vaccinated, but in a time frame where vaccination was available, even the non-vaccinated women, not surprisingly, due to a herd effect, meaning they might have exposed males who didn't get it, didn't have a persistent infection because they had sexual relations with women who had been vaccinated, etc. A herd effect, there was a reduction, even the women who hadn't been vaccinated, on a population basis during the interval of time that HPV vaccination was available. And finally, it's absolutely critical to highlight a landmark paper recently published in the New England Journal of Medicine that reported a trial that looking at single HPV vaccination to 2 doses of the vaccine in a trial of 20,000 participants in Costa Rica, looking specifically at HPV 16 versus HPV and it's HPV 18, the major culprits, not only, but major culprits in the risk of cervix cancer, and demonstrated that there was no difference in the benefits of single dose versus 2 doses. A very important observation, particularly in settings where it is hard to even get a single dose in rural areas, socioeconomic concerns, the ability to get populations together. The question is, and I'm going to talk about this on the next time, is should that become the standard single dose based upon this one, and even a few other trials, based upon the data available now in terms of longitudinal follow-up? More to come on this question in the next segment of Minutes with Markman, and I thank you for your attention.